what you want. You want to go in the room? Come on. Come on.
Hi, I'm Vic Sidis. And welcome to Chicago Metro SUNA's Zoom meeting. I see we've got a few people tuned in already. I'm going to get this meeting started by turning it over to our president, Lisa Shimkus, for a few announcements. Lisa, go ahead.
Okay, thanks a lot, Vic. Yeah, hi, Lisa Shimkus here, president of SUNA, Chicago Metro chapter. We want to welcome everybody tonight to our first Zoom virtual roundtable. We hopefully, I think we had quite a few participants from different states, so I'm hoping that they'll jump in and we can see where everybody's from. It's such a great way to network, so hopefully we can have more of these in the future. Just a couple announcements here. The Chicago Metro Spring Conference is going to be March 27th. It's a virtual event, so sign up for that. Our National SUNA Advanced Practice Conference is April 17th and 18th. Again, that will be virtual for all of you that are interested. Also, our National SUNA Urologic Conference is scheduled to be in St. Louis, October 28th through the 31st, hoping that'll go live. So again, just kind of keep that in mind. Our National SUNA website offers scholarships for the Sabuna recertification and also for the conferences. The deadline for the applications are February 15th. It's my understanding so far nobody has applied for these. So these are great scholarships. So I would encourage you all to apply. Be sure to check out on the National SUNA website, the EuroConnect, to network with more members. And we're always looking for new and different topics that you would like us, to talk about, have roundtables on, or for our conferences. So if anybody has any ideas for next roundtables or conferences, we love to hear from anybody. We're on Facebook and LinkedIn. And also on our Chicago Metro website, we have a virtual coffee can, and we encourage, if at all possible, donations. Our donation is to the local food pantry. And lastly, we got the award. Everybody can see it. There's a little bit of a glare for the 2020 Chapter of the Year. We're very proud of it. So congratulations to all of the Chicago Metro members. Now, I just want to go ahead and introduce our speaker, Hilda Salgado. She's a PA, and she worked at the Metro Chicago's Surgical Oncology, and they have offices in the northwest suburbs and Chicago. She's going to give a short presentation on BCG and I believe bladder cancer, and then we were going to open it up to questions and discussion. So thanks so much, Hilda.
Thank you, Lisa, and hello to everyone, and thank you for joining us tonight. Can everyone hear me okay?
Yes.
Yes.
All right, so I am going to start off first by presenting some background information on bladder cancer, BCG, and other chemotherapy agents, and the current recommendations. Next. So bladder cancer is the most common malignancy involving the urinary system. The most common type is urothelial, or formerly known as transitional cell carcinoma, and it accounts for 90% of all bladder cancers. It is the fourth most common cancer in men in the US, with a median age of 70. The most common cause is smoking, and the most common presenting sign is painless gross hematuria. If a patient presents with microhematuria, a full evaluation is recommended in men greater than 40 or women greater than 50 and with risk factors. BCG is the standard treatment option for non-muscle invasive bladder cancer, which consists of carcinoma in situ, Ta papillary carcinoma, and T1, in which the tumor invades the submucosa or lamina propria. Next. BCG is short for Bacillus calmette-guerin, named after its developers Albert Calmette and Camille Guerin. They had isolated an attenuated live strain of the bacteria, Mycobacterium bovis, which was first isolated in 1904 from a cow with tuberculosis mastitis. This was then used as a live vaccine against TB. Several substrains were then developed, as shown here to the right. The two strains, Conag and Tice, were the only ones that were approved by the FDA. And the Conag strain is the one that was discontinued, thus resulting in the shortage. Next. Dr. Alvaro Morales devised the original protocol for intravesical BCG. In his study, he instilled 120 milligrams of BCG diluted in 50 mL of normal saline via a urethral catheter and into the bladder of 9 patients. He found that it took 3 to 6 weeks to mount an immune response. The regimen consisted of a weekly dosing to minimize the side effects, as they were noted to last 1 week. Treatment was given over a period of 6 weeks due to packaging at that time that came in vials of 6 and because of the time needed to mount an immune response. He showed that there was a decrease in recurrence and/or eradication of the tumor in 7 of the 9 patients. The first randomized controlled study proving the effectiveness of BCG on non-muscle invasive bladder cancer was performed in 1980 by Lamb and colleagues. The exact mechanism of how BCG works is unknown, but it has been suggested that it attaches to the tumor cells, which then elicits a local immune response to the BCG antigens, but instead acts against the tumor cells instead of the BCG antigens. Next. What we now use as the BCG induction and maintenance dose and schedule came from the SWOG and EORTC trials. The induction therapy consists of 6 weekly bladder instillations, starting 2 to 6 weeks after TURBT. Each dose consists of 1 vial of the Tice BCG diluted in sterile saline and is instilled via urethral catheter by gravity flow or gentle push installation, and the patient retains it for 1 to 2 hours. Maintenance therapy is recommended at every 3 months for 1 year in intermediate risk patients and up to 3 years in those that are high risk. Next. So why is there a shortage? There are originally 2 manufacturers of BCG. Sanofi Pasteur made the Conag strain and Merck the Tice strain. Due to inconsistencies in manufacturing, Sanofi Pasteur went offline in 2012 and completely shut down production in 2017. Merck is currently the only one producing BCG worldwide, but its demand is greater than its production and they're at full capacity. The manufacturing process is lengthy and complex, as each batch takes more than 3 months to make, and the growth of the bacteria alone takes 30 days. Next. In response to the shortage and to increase production, last fall, Merck announced plans to construct a new manufacturing facility, but it will take 5 to 6 years before it's completed. In the meantime, Merck distributors such as Bessie Medical, McKesson, and others have put in place a system to proportionally allocate Tice BCG based on historical demand within the US and other countries. Also, other countries, Japan, Canada, and Europe, they're working to develop their own strains of BCG, but then they would need FDA approval. And the FDA is currently testing the Tokyo 172 strain. Next. In response to how to treat non-muscle invasive bladder cancer with the BCG shortage, a joint statement was released by the Finally organizations last fall with management recommendations using other intravesical agents. Next. For low-risk non-muscle invasive bladder cancer, BCG should not be used. So these are patients that have a primary solitary low-grade TA tumor less than 3 centimeters in diameter and no carcinoma in situ. Instead, they should get a single dose of intravesical chemotherapy administered after TURBT and put on surveillance. Next. If they are intermediate risk, so those are low-grade TA lesions that recur or multifocal, low-grade TA greater than 3 centimeters, high-grade TA less than 3 centimeters, or low-grade T1, they recommend intravesical chemotherapy with the following agents: mitomycin C, gemcitabine, epirubicin, and docetaxel. Next. For high-risk patients, that is, they have high-grade TA greater than 3 centimeters, high-grade T1, any carcinoma in situ, and BCG failures in high-grade patients, the recommendation is to use full-strength BCG or reduced 1/2 to 1/3 of the dose to use in multiple patients. And this is to be used for induction and for 1 year of maintenance, if the supply permits, otherwise prioritized for induction only. And these are the intravesical agents that are recommended for use if the BCG is not available. Next. For those with high-grade T1 plus high-risk features, the recommendation is a radical cystectomy or a clinical trial. Next. For post-op intravesical chemotherapy, it is recommended for low-grade disease, and it's usually administered within 24 hours of TURBT. The agents used are gemcitabine and mitomycin C. Next. Intravesical agents, there is mitomycin C, gemcitabine, epirubicin, and valrubicin. These are cytotoxic agents that inhibit DNA synthesis in bladder cancer cells. And because they are cytotoxic, it's important that they are prepared using aseptic technique and using PPE. So that is chemotherapy gloves or double gloves, a disposable non-permeable gown, a surgical mask or face shield. All equipment, supplies, and receptacles in contact with these agents are handled and disposed of as chemotherapy waste. And the medication should be marked for irrigation only to avoid any accidental IV administration. Next. Mitomycin is prepared by reconstituting 40 milligrams in 20 mils of sterile water. Again, because of the kind of agent that it is, it should be prepared in a biological safety cabinet. If one is not available, then a mask and double gloves should be worn and used mixed in a closed system drug transfer device. Avoid any skin contact as it is a vesicant. And then the medication is instilled via catheter by gravity flow or gentle push installation. Next. Gemcitabine comes in 1 gram or 2 gram vials of powder or pre-mixed with a closed system administration set. The 1 gram is reconstituted in 50 mils of normal saline. 2 grams is reconstituted in 50 to 100 mils of normal saline, and then instilled via catheter by gravity flow or gentle push installation. Next. Docetaxel is reconstituted as 75 mg per mil of normal saline. It is instilled again via catheter by gravity flow or slow push over a 5-minute period. Next. The combination of gemcitabine docetaxel involves instilling the gemcitabine via a urethral catheter. The patient retains it in the bladder for 60 to 90 minutes. And after the 60 to 90 minutes, it is drained from the bladder and docetaxel is instilled. The catheter is removed and the patient will retain it in the bladder for 60 to 120 minutes. Next. Valrubicin. Each vial contains 200 mg per 5 milliliters. You allow 4 vials, so a total of 800 milligrams, to warm to room temperature. You withdraw all 20 milliliters and dilute those in 55 mils of 0.9% sodium chloride. And you instill the 75 milliliters of the diluted solution via catheter by gravity flow over a period of several minutes. Next. So other options include delaying treatment. In those patients of low risk or recurrence, or those in the 2nd year of maintenance, for surveillance, there is now blue light cystoscopy or narrowband imaging that can significantly enhance the detection of bladder tumors that would otherwise be missed with white light. If the first surveillance cysto is negative, then the recommendation is for subsequent surveillance cystos can be done every 6 to 9 months and then annually in low risk patients. For intermediate risk patients, a cysto with cytology should be done every 3 to 6 months for 2 years, then 6 to 12 months for years 3 and 4, and then annually. For high risk patients, a cysto and cytology should be done every 3 to 4 months for 2 years, then every 6 months for years 3 and 4, and then annually thereafter. Urine cytology is not recommended in place of cystoscopy, but I have seen it done in older patients that have had negative cystos. And then there are also urine-based tumor marker tests, which are also not recommended for low-risk patients with negative cystos. But again, I have seen it done for surveillance instead of doing a cysto. But urine cytology and the urine-based tumor markers can be used to assess the response after intravesical therapy. Next. So these are some tips and suggestions that were shared with me. It's important to have a spill kit available because spills can happen and patients can have bladder spasms that can cause a chemo spill. Also use caution when mixing undiluted urine with bleach. The active ingredient in bleach is sodium hypochlorite, and when it reacts with ammonia in the urine, it produces toxic gases called chloramines, which can cause the following side effects: coughing, nausea, shortness of breath, watery eyes, chest pain, and irritation to the throat, nose, and eyes, wheezing, pneumonia, and fluid in the lungs. Next. Okay, and like I tell my daughter after we read a story, the end.
Oh.
I will now open it up to any questions or anyone else with any other tips.
Okay, so everybody's shy, right?
I did have a question about the agent that you said that you instill it for 60 to 90 minutes and then the patient waits. I mean, we're in a urogyne practice. I'm just curious. So did they wait in the office for 60 to 90 minutes and then you instill the next agent, or how does that work?
That's what I read. We don't use, in our office, because we're a small private practice, we don't use that agent. So I'm not sure who others who have used it, if that's their protocol or not.
I can comment on that. The patients that in the past I have worked with where we did intravesical treatments in the clinic, they did stay in the room because if they had a bladder spasm, then we would have a chemo leak somewhere, you know, maybe in the
Okay.
Oh, yeah.
cafeteria or the lobby. That would be really bad.
Oh, gotcha. Okay, I see.
There's some urologists who with BCG only would allow some patients who lived nearby to drive home and void there and use the bleach in the toilet at home. But then there were concerns that if they were in a car accident on their way home, there could be chemo could spill or leak out during the accident, and the first responders wouldn't know that
I see.
chemotherapy. So then that was ruled out. So it was very difficult to accommodate the room space for that amount of time. But that was what was done for a while, where a place that I've worked at in the past. And then eventually it got moved to the cancer center where the infusion nurses would do it because they had more availability. And it was a little bit more safe for those patients because it was a wide open space where if the patient was having a reaction or had something that they needed immediately, those nurses were available.
I see. Interesting. Okay.
Yeah.
Yeah. Just curious.
So what has everyone's experience been as far as shortages of BCGs? Everybody's office have enough, or what are we seeing out there?
Our office has been able to get it through McKesson. They were using Bessie Medical, but the person who gets it says that they were, because of the allocation, they were being a bit more stringent about it. So they were going through McKesson. That's how we've been getting ours.
So you've had enough to treat all the patients that you normally see?
Yes, yes.
And I guess one question I would have, I guess from a patient standpoint, is I'm sure the patients hear all about all of these shortages, and then, you know, how do you counsel them without kind of scaring them or, you know, letting them think that they're not maybe getting, you know, the best treatment, the right treatment. So I'm sure that's a little, what do I want to say? You have to be careful when you counsel them, I would assume.
I know in our practice early on when the shortage first hit, we tended to game the system by finding out from a rep similar to what Hilda was talking about, who said, on this day, you can order this many. This is what the allotment would be. And we would order all the time. And then we kept a list of patients that were, you know, needed BCG. And then as we got supplies in, we would put 6 away for that patient and then bring them in and give them their treatments that helped for us.
Oh, I see. Okay. So it would depend upon like how, because the growth you said is it's the 3-month growth for the BCG to grow out for these different manufacturers, correct?
Well,
So
the the shortage was preventing the normal supply. You couldn't say, I got a patient, I need 6 vials sent over. It was, I have a patient, they tell you we have nothing to ship. So we
I
just
see.
started ordering it. They were saying we could order, I think it was 8 vials every other week. We would just order it automatically. We had that volume of patients.
Okay.
And is it, I probably, Hilda probably said it, but is it like a powder, then you reconstitute it so you can keep it for a long time, or expiration date, shelf life?
It's freeze dried. It's kept, you reconstitute it at the time of use and it's kept refrigerated.
Okay, okay.
You have to use it within an hour of reconstituting it.
Oh, okay.
Well, I think, Vic, that's why, since being in a hospital location, we were having trouble having the hospital get one every time that we needed it. That I think the physicians that we worked with now started just doing that in their offices. Maybe they're doing exactly what you were saying and just ordering a certain amount, and we can't do that in the hospital base. So I think they've been doing all of that in their offices more, and we haven't really seen much of any bladder installations for BCG in a long time.
Wow. And is there any studies to say that like these other agents are just as good, or, you know, is the BCG still the gold standard? Probably.
It still is, but they do have some studies, and I should have pulled some up, but that they are showing that it can, you know, there's less recurrence. And then also that's why surveillance is important, you know, doing the cystoscopies, and that's why they recommended, you know, doing them depending on how their risk, how often they should be cystoed, you know, with the cytology.
That makes sense.
I have a question. There's been some patients in the past with issues where they already have an overactive bladder for results of many different health problems. Has anyone used a medication to be used beforehand, like a ditropan or anything, to help prevent those bladder spasms during installations?
Yeah, we've done, yeah, like any of the anticholinergics or Myrbetriq, and then also what we used to do would be cut down on the dose of the BCG. So I think the lowest dose that we used on a patient, because they had that problem, they couldn't retain it, was 1/8, and that was still effective for them.
Wow.
So I never had much luck with the anticholinergics. So what I did when we had a patient that would have that issue is the way it's given, if most of us probably know, it comes in a vial that goes through a tube and through a catheter. So I would just leave that system, since it's closed, hooked up for the 2-hour dwell time, pad the patient. And what I found is, as I got a bladder spasm, it would just go back up into the bag. And then as the spasm relieved, it would go back down into the patient. And I had a lot of success with the patients that had that issue with that setup.
So you had the bag high up, you mean?
Yep.
Oh, interesting. Okay. Oh,
That was
Right.
good.
So gravity feeds.
right. Yeah. So, okay.
Oh, that's a really good idea. We had a patient once. He kept having bladder spasms, so we put a Foley in and we plugged it, and that didn't work.
Yeah,
Leaked
we
around
tried
it,
that
yeah.
too, and it didn't work. That's why I like Vic's idea. I've never heard of that one
That's
before.
a good idea. It's like reverse grad. That's a good idea.
Yeah. I mean,
Wow.
it's a closed system, so why not take advantage of it?
Yeah.
Yeah.
Oh. Cool.
I did have one more question, just because like this is not our practice, obviously, with urogynecology, but I did have my father, who's now passed, in the year 2000, had transitional cell carcinoma, and they originally did the BCG, and he had before his radical cystectomy, I think he had maybe six treatments, but then like the 7th or 8th when he got sepsis. And so then they proceeded with the radical cystectomy. But I guess I'm curious, and this was, I guess this was in the year 2000, but I remember the urologist telling me a percentage of people that would get septic with, at some point with these treatments. And, it's been so long ago, but it's like, because he was doing well with it, and then I think it was at 7th or 8th, he just got, really, really sick, really septic, and they had to stop them, and they treated it ended up with surgery. But Is that still a big risk, being septic, getting septic from these?
I've seen it happen twice.
Okay,
So
I think I agree. The precautions are no hematuria. They can't have any blood in the urine at all,
okay,
and no infection, because those two things will make them higher risk for sepsis.
okay. I was just kind of, I would, it's one of those things where, I mean, I didn't know anything about it certainly, and he lived like 2 or 3 hours away from me, so I just was, I was always kind of curious about that.
Yeah, I've seen it once in the 5 years that I've been in urology.
Really interesting.
Yeah,
Okay.
and it's also really important to document everything. So, I mean, we do a urine dipstick before and ask the patient if they have any symptoms. And so for that patient that became septic, I actually had sent in a urine culture. It came back negative, but that's what, because he ended up having multiple strokes and sepsis. So they were blaming it on the BCG, but he was actually a smoker that was non-compliant with his medications. But so that was really important, was documenting that, yeah, we do a dipstick, we ask them for the symptoms. And then after every treatment, I go through all the symptoms with the patients. Okay, remember to call if, you have this, or make sure that, look out for all these signs and symptoms.
Okay, interesting.
I just have a comment about chemotherapy safety, because one of the institutions that I was working at required that we have a special class with a certificate from the Oncology Nursing Society, ONS.
Yeah.
And they were saying that any nurse that was of childbearing age or trying to conceive, male or female, shouldn't be handling the chemotherapy agents. I haven't really seen that done in practice. I see a lot of people that are young or trying to conceive doing that. What have you seen in your practices? Are they strict about who could administer, or?
At least in the small private practices that I have worked at, it's, you have a title, here you go, learn how to prepare these agents, and they don't even tell you to wear a mask or, double gloves or anything like that, and take any kind of precautions. Yeah.
Not even a mask?
No, but I used to work in a lab, so I would always read the package insert, and so that's how I knew that we had to be careful in handling these agents. But yet in both practices, it was like, here you go, figure it out.
Yeah.
I don't know if in the hospital, do they need like special training or?
Yeah, they do. Because I was in the infusion area, because I did research, but I was in the infusion area and I gave all the medications that were experimental. And I had to be ONS certified to do that, besides the company that I was dealing with, or if it was with NIH grants, they came out and we had special classes we had to go through. And you had to have you had to have protection. I mean, there was no ifs, ands, or buts about it.
Yeah.
A lot of these chemotherapies should be mixed in a hood.
Yeah.
So
Exactly.
if you don't have that in your office, then you need to be able to coordinate with a infusion center to pre-mix your therapies.
Or a pharmacist. I mean, if you're working,
Yeah.
if you're close by and you have a pharmacist you're working with. And,
Yeah.
and you're absolutely right with the spill kit, because, you just never know when you need it. And if you have it available, it becomes almost, second nature to you to have it. But
Yeah.
the drugs that they're using now, I've used IV chemotherapy with. So, I mean, the side effects, you really have to be careful. And when we would give it, we'd give it very slowly at first. So, I mean, if they had a reaction, you're on top of it, you can stop it.
Yeah, I think the best case scenario would be asking all of your nurses who are administering any of these chemotherapy agents, or any other staff members involved, to get that ONS certification, because I learned a lot about chemo safety in that course that I didn't know before.
It's the biotherapy course.
Yeah.
Makes sense, definitely.
Could be a good subject for one of our conferences.
Yeah.
Yeah.
You know,
Yeah.
and the course
Infusion
is
safety.
interesting, because you're right, it goes through, and then you have to recertify after, I mean, because you do get a certificate and you have to recertify. I'm not sure now if it's every year because I've been out of it for a few years, but I would go in and I'd reread, especially if it's a drug I haven't used in a while. It's like, oh shit, what are the side effects? Let me look it up. And then I had my own manual so I could take, you know, it with me and then, you know, give it to the patient too, so that they would be aware of it.
Mhm.
Yep.
Yeah. I bet there is quite a bit of patient teaching, and that must take quite a bit of time for the patient and the family.
Yeah,
Are
definitely.
you guys using all of these other medications and infusions or bladder installations in your offices? Aside from just the BCG, are you doing those installations in your offices as well?
The only one we use besides BCG is Valstar. The other ones we were using, but we didn't get a lot of success with them.
The mitomycin you weren't getting success with either?
They were using that in our OR post.
As I say, we had an OR protocol for that.
Okay,
in the offices.
Give it immediately post-op.
correct.
Yeah.
I've used mitomycin, gemcitabine, and docetaxel over the years.
And
I'm not sure what the outcomes were for the patients though.
I used mitomycin C for one patient that was refractory to BCG, and then we used Valstar for one that was refractory to both mitomycin and BCG.
I had a thought about catheters. So what if you have a patient doing CIC and is also in need of an intravesical therapy? Do you send that patient home with gloves and a chemo bin? And how, will the chemotherapy get on the catheter? Are there concerns with that?
In our case, we always catheterize them ourselves.
I was gonna say.
Instill it, leave it in, and then bring them back in to drain it.
Okay. And then after it's drained, there's theoretically no risk after that, or?
Probably much lower risk.
Yeah.
They should still be using, precautions.
Very interesting.
Yeah.
Yeah. I think we're missing, some. How many, Vic? We had a couple more. Hopefully
Yeah.
they'll listen to it.
We are recording this, so we will make it as an on-demand availability. So
Nice.
Great.
another option. Appreciate everybody who did show up for tonight. This is kind of that new world that we're all going after, right?
I think it's great though, if you can do this on a monthly basis and you're in your own home, you don't have to go anywhere, but you can, talk to other, nurses and professionals in other offices. And I think it's great to listen to, what everybody does in their different situations, and private practice versus hospital, versus clinic. So all very interesting. So
Yeah. And thank you so much, Hilda, for that excellent
Yeah,
presentation.
very good.
Yeah.
Very informative.
Very good.
yeah.
Now I should be getting the flyer for our February 25th little conference that we're going to have, or the presentation, I should say. And that's going to be on renal cancer.
Great.
Great.
So Vic will get it, and then everybody has to sign up that way.
Okay, good. Yeah.
We get a CE for it.
Oh,
Oh,
good.
nice.
Okay,
That's always good.
Yeah.
I think these are great.
Great.
You
Any
did a
other-
great job, Hilda. Thank you for
You're
that.
welcome.
It's great.
Has anybody gotten their COVID vaccine
Yeah.
yet?
Both of ours.
I got my first
We're,
one.
we're both vaccinated. We've got doubles.
Yeah.
Good.
Yeah.
It's fine. No problems at all. I mean, a little bit of barely a sore arm. Really, is fine.
Yeah.
Yeah, it's a little bit more than a flu shot on the arm soreness, but other than that, I had no other reaction for the first one. So hopefully the second is the same thing.
I think we heard one of the nurses near us, Nancy, did you say had a fever of 103?
A friend of mine in Denver, she's a family practitioner, and she was in bed for 2 days with 103 temp. I
Really?
was getting
It
kind of
happens.
nervous, like, oh my gosh, I wonder if I've got COVID, but it subsided. It was like 48 hours. And then, yeah.
Well, there is a
In
problem.
our facility, I'm hearing more that the older the person that got it had less reaction. The younger ones were having more reaction.
Well, that's why I had no
Different body
reaction
ache.
then. No wonder.
Now, California had a problem and they're looking into their lot number. They think
Right.
there might be a problem with the lot number.
Yep.
Wow.
Yeah,
think
I'm
that
glad.
was,
It feels good to be done with it, you know,
Yeah, you feel a little safer.
Yes.
a little bit. I
Yeah.
felt safe. My pedicure this past weekend, I felt a little safer. A little less guilty or something. I don't know.
There you go.
Yes. Well, if anybody has any ideas for future, roundtables, like email us, let us know. I think,
Yeah, I think this is definitely something we'd like to do again.
Yeah. And even if, like for Nancy and I, this isn't our specialty, but it's really interesting to hear because I think it can encompass all of urology. So it's really nice to learn
Yeah.
everything. And then also if anybody's studying for their exam, you know,
Absolutely. Yeah.
so
Yeah.
things like this can really help. So, all right. Thanks, Vic, for
All right. Well,
organizing
Yeah.
this.
Good job.
great.
We wouldn't be able to do it without you, that's for sure.
I know. Don't leave us, Vic.
I'm not going anywhere, I hope. I hope you all found tonight's meeting informative. We look forward to future virtual meetings and hopefully live meetings someday soon. Stay
Yeah.
healthy and enjoy the rest of your night.
Thank you.
Thank you.
Great.
All right. Good
Everybody.
night, everyone.
Everybody. Thank you.
Bye.
Bye. Bye, Charlene.